Good evening, students. Have you all joined in? Good evening. Are you all there? Can we start the session? I'll just wait for 2 minutes so that everyone can join in. So shall we start? Is the audio, video, everything fine? Okay. So today's MCQ based session that I have with me today is majorly of PYQs, that is your previous year's questions. And I have tried to pick the confusing ones so that I can explain you how to choose your answers. All right, fine. So we'll start with the first question. A female was given local anesthetic for a surgical procedure. After injection, she developed drooping of one half of the face, inability to close the eyelid, inability to frown. What is the cause? All right. So option A is injecting too deep into infraorbital foramen. B is posterior injection while giving mandibular nerve block via Rani-Akinosi technique. C is too lateral injection while giving PSA block. And option D is maxillary block from palatal approach. Alright. Good evening, Monirudya. Okay. The voice is not clear. Okay, I'll speak to the technical team. Alright. And I will get the videos rechecked. Okay. Don't worry. Alright. So all of you, please answer this question. Write the question number and the option along with it, and your answer along with it. Okay. So what would be the answer to this question here? Okay, more answers? Okay, now let's understand this question. This question has said that the patient has been given local anesthetic solution. All right. And after which she developed drooping of one half of the face, inability to close eyelid, and inability to frown. All right. Now, please understand that these are signs and symptoms of facial nerve paralysis. All right. inability to frown, inability to lift the eyebrow, inability to close the eye on one side, drooping of angle of mouth on the one side, all right, inability to blow air on one side, inability to smile, all right, on one side. So these are all signs and symptoms of your facial nerve paralysis. All right, once you figure out this from the question, then you can very easily rule out option A and option D. Okay, because an infraorbital nerve injection will never cause facial nerve paralysis, and also maxillary block from palatal approach will not cause facial nerve paralysis. All right, now we have option B and C remaining. All right, in C, when the injection is too lateral while giving a PSA block, even then it can be confusing, but when you are giving a PSA block, even for option C, you will not be encountering your facial nerve. Okay, now when that leaves us with option B, which is the correct answer. Now, so that you people don't forget, please understand the concept behind why is this happening. So at your posterior border of the mandible, all right, this is where the parotid capsule is present at the posterior border of the mandible, and it is going a little medially. All right, so if you give two posterior injection, all right, the LA may get deposited in the parotid capsule, all right, which will cause or which will stun the facial nerve for some time. All right, so you can also be asked the treatment. So once the facial paralysis has happened, you don't need to do any treatment. You just need to reassure the patient that once the anesthetic effect wears off, you will regain your function and the patient should not panic. All right, so this is an additional point. Let's come to the next question. A patient undergoing dental surgery collapsed on chair and became unresponsive. History showed that the patient was taking prednisolone 20 mg per day for the past 4 months. Following collapse, patient was given oxygen by mask and 100 mg hydrocot injection IV, and vitals were monitored. What do you think the patient suffered from? Option A is acute renal insufficiency. Option B is syncope. Option C is hyperaldosteronism, and D is acute adrenal insufficiency. So what would be the answer over here? Please let me know in the comments. Okay, more answers? Yes, so the correct answer here is acute adrenal insufficiency. Okay. Now, 2-3 very important points. So here the patient is already taking patient is already taking steroid. You have to, yes, I'm coming to that, Akansha. That is what I'm telling you, a few points regarding this question. Here the patient has already been taking steroid. He is currently on steroid. Alright. Now there are another things. Such patients will definitely likely develop acute adrenal insufficiency if you don't manage accordingly. Now there is something known as rules of two. Okay. So if the patient has taken 20 milligram of steroid for 2 weeks or more, and within 2 years of dental treatment. Alright, you have to remember rules of two as well. So, one, if the patient is currently on steroid, you have to manage the patient. But if the patient has taken or has a recent history of taking steroid, okay, then also in that patient there is a chance that there would be acute adrenal insufficiency. Alright, now how do you manage? Suppose if the patient is already taking steroid, how do you manage such patients? Alright, so when to double the dose? Day before surgery, on day of surgery, and day after surgery. You will double the dose. Alright, you will double the dose. And second day after surgery, you will return to normal dose or what the patient was taking. Alright, is this clear? So you have to remember rules of two, and you have to remember when to double the dose and when to return to the normal dose. Alright, and for that you have to know what dose the patient is taking. That is important. No, antibiotic prophylaxis will not be required in a patient who is taking steroid. Alright, it won't be required. Fine. Okay, Akansha, I hope your doubt is clear now. Now let's come to question number 3. Type of intubation used in a cleft palate patient is A. Fiber optic, B. Orotracheal, C. Submental, and D. Laryngeal mask airway. So please let me know the answer to this question. Please tell me the answers. Okay, so the answer here is not C. Okay, answer here is not C. Answer here is B. I'll explain you why. Now for a cleft patient, okay, cleft patient, especially a cleft palate patient, is somewhere between 9 to 18 months of age, is a very small baby. So you avoid any invasive type of intubation. So submental is usually not done. Okay. Now, for a cleft patient, if you notice a cleft patient, the nasal anatomy, the palate is open and communicating with the nasal cavity. Alright, and in a cleft patient, the nasal anatomy is usually distorted. Alright, nasal anatomy is usually distorted. So for a cleft patient, we also don't prefer a nasotracheal intubation. Okay, for a cleft patient, usually a oral intubation is the one which is the most preferred. Alright, now please understand, when we are doing cleft palate repair, we are not bothered about our occlusion. Alright, usually in maxillofacial surgeries we use our nasotracheal intubation so that our occlusion we can assess or we can work freely in the oral cavity. Alright, so but nasotracheal intubation cannot be done in a cleft patient because the nasal anatomy is distorted. Alright, so just I have a visual over here. Okay, and I'm going to zoom out. Right, this is a cleft lip and palate repair. Alright, now if you see the nostrils of the patient, the nasal anatomy is distorted. Even the normal nostril seems to be a little deviated. Alright, so we cannot do a nasotracheal intubation in such a patient. We can do a orotracheal intubation. Alright, now orotracheal intubation, because we don't have to assess the occlusion on table. One. Alright, but for a orotracheal intubation, even better intubation, the best intubation actually is a South Pole RAE. Alright, South Pole RAE is the best, which is oral RAE. Alright, which is your oral RAE, South Pole RAE, followed by your orotracheal flexometallic tube. And if you see in this patient here, in this child here, the intubation is done, and instead of taking the tube up towards the head end, the tube is taken down towards the feet end and then taped over there, so that your upper field of surgery is free. Alright, so that your upper field of surgery is free. Understood? All of you? Why we do a orotracheal intubation? Best would be South Pole RAE, which is your oral RAE, followed by a orotracheal flexometallic tube. Okay, I hope it is clear to all of you. Intubation, I understand, can be a tricky thing because you people are not too much exposed to it practically. Okay, so I hope this doubt is clear, that orotracheal is the answer over here. Okay, please let me know if this is clear or if there are any doubts with this. North Pole is done via nasal. Okay, Akansha, and South Pole is done via oral. Okay, all right. Okay, why other options are incorrect? Let us come to fiber optic. All right, fiber optic is mostly used for nasal intubation. Fiber optic is used when there is a difficult airway present, and it is mostly used to insert the endotracheal tube in the nasal cavity. Okay, but here we are not going to use a nasal tube, so that's why fiber optic is contraindicated. Submental, like I just told you, you can see this small is the baby. You would like to avoid any sort of, alright, any sort of invasive procedure. Already the child is going to go through a series of surgeries. Any sort of invasive procedure is to be avoided. Submental, you make a submental incision and then do the intubation. Okay, and laryngeal mask airway is basically a airway device which is used for very short duration surgeries. Alright, it is used for very short duration surgeries. Here we are supposed to have a secure, it's a pediatric patient, we are supposed to have a secure airway, a definitive airway. Alright. No, submental intubation will not provide any hindrance, just that it is a invasive method. Okay. And cleft lip and palate children, they keep undergoing a series of surgeries till their teenage life, so that is why we avoid it. All right, I hope all doubts are clear. Okay, can we move on to the next question? Yeah, laryngeal mask. Your laryngeal mask airway, if you go back to my lectures also, I have um, explained it with the help of a visual. So laryngeal mask airway is used for very short surgeries. Alright, it is used for very short surgeries. Okay, orotracheal intubation is a more definitive airway which gives better control to the anesthetist during the procedure. Alright, so we have to be safe with the child. Alright, we have to be safe, that's why we prefer orotracheal over laryngeal mask. Alright, is it clear? Okay, we'll move ahead. So coming to question 4 now. In Winter's war lines, red line depicts A. Depth of impaction, B. Angulation of second molar, C. Level of alveolar bone covering the impacted teeth, D. Level of CEJ of the second molar. What would be the answer over here? Okay, I will explain about definitive airway. All right, Komal. More answers, please. Okay. So, Winter's war lines, the red line depicts, it does not depict the level of alveolar bone covering the impacted tooth. It actually depicts your depth of impaction. Alright, it actually depicts your depth of impaction. This is your answer. Now, quickly, let's just understand wall lines. All right, let's just quickly understand wall lines. Now, Winter's wall lines, WAR. So, W stands for white, A stands for amber, and R stands for red. Okay. Now, the white line is drawn at the level of the occlusal plane. Alright, so it is drawn from the occlusal surfaces of the first and the second molar, and it is extended backwards distally towards the third molar. This one. I'm drawing it with the help of a pink pen. This is your white line. Okay, fine. Now, the amber line. Alright, the amber line is drawn from the bone that is covering or the bone that is distal to the third molar, and it is extended forwards. Alright, I'm using an orange pen. So you trace the bone which is covering the impacted tooth or which is present distal to the impacted tooth, and you extend it forwards while joining it with the interdental septum of the between the first and the second molar, and between the first molar and the premolar. Alright, this is your amber line. Okay, this is your amber line. Now, from the amber line, you draw a perpendicular or you drop a perpendicular at the point on the third molar where you will apply your elevator. Alright, so if this is the amber line here, from this amber line, if you have to apply your elevator here, you will draw a perpendicular over here. Okay, similarly here, if this is your amber line and you have to apply your elevator here, you will draw a perpendicular to the point where you have to apply your elevator. Okay, fine. So now see, white line denotes depth of impaction from occlusal plane. Why? Because you're drawing the white line at the level of occlusal plane. Okay, amber line denotes the depth of impaction within the bone. Why? Because you're drawing the amber line in reference to the bone distally, or the bone which is covering the third molar. And red line denotes the depth of impaction with reference to amber line within the bone. Alright, so all your lines are denoting depth of impaction but with a different reference point. Okay, this is the idea behind war lines. Understood, all of you? Nikesh, Samriddhi, Ashish, Komal, Feel the Dentistry, Genia. Hope it is clear to all of you now. Okay. I hope ward lines also with this diagram you have quickly revised. So it is always the depth of impaction. Also, please remember the amber line is drawn to the mesial CJ in case of mesoangular, vertical or horizontal impactions, and the amber line is drawn to the distal CJ in case of distoangular impactions. Understood? Okay, good. Coming to question number 5, TMJ issues in rheumatoid arthritis presents as TMJ subluxation, option A, option B, TMJ ankylosis, option C, recurrent TMJ dislocation, and option D, restricted TMJ movements. So please let me know the answer to this question. And please mention the question number along with your answer. Yes, more answers. Yes, so option D is the correct answer. So whenever the patient will have arthritis or rheumatoid arthritis or arthritic changes in the joint, the patient will experience restricted painful TMJ movements. Alright. Now, coming to question number 6. Horizontal favorable fractures of mandible is seen when the fracture line is oriented. Option A, anterolateral to posteromedial. B, posterolateral to anteromedial. C, forwards towards alveolar process from inferior border. And D, backwards towards alveolar process from inferior border. So what would be the answer over here? Yes, so the correct answer is backwards towards alveolar bone from inferior border. This is the correct answer. Alright. Does anyone want me to repeat favorable and unfavorable, horizontally unfavorable or horizontally favorable fractures? If anyone wants me to repeat, please let me know. I'll quickly revise in 2 minutes. Or if it's clear, then we can move ahead. Alright, we'll move ahead. Coming to question number 7. Okay. Surgery for cleft lip is based on rule of 10, which is A, 10 weeks, 10 pounds weight and 10 gram% hemoglobin. B is 10 weeks, 10 kgs weight, 10 gram% hemoglobin. C is 10 months age, 10 pounds weight and 10 gram% hemoglobin. D is 10 days age, 10 pounds weight and 10 gram% hemoglobin. So what would be the correct option over here? More answers? Okay, so the correct answer here is 10 weeks, 10 pounds and 10 gram percent of hemoglobin. Alright, so there is rules of 10 in which the baby should be 10 or more than 10 weeks old. So this is your age. The baby should weigh 10 pounds or more. This is the weight. And the baby should have 10 gram percent or more of hemoglobin. This is the hemoglobin that we have to consider. Alright. So these are the three parameters in rules of 10 for a cleft lip only. Cleft lip repair. Okay. For a cleft lip. Alright. So all of you who are marked B, is it understood? Shall we move ahead? Okay, great. Now, coming to question number 8, Carnoy solution is composed of option A 60% ethanol, 30% chloroform and 10% glacial acetic acid. B 30% ethanol, 60 glacial acetic acid and 30% chloroform. C 30% iodoform, 60% ethanol, 10% acetic acid. And D 30% ethanol, 60% glacial acetic acid and 40% iodoform. So what would be the correct answer over here? More answers? Yes, so the correct answer would be 60% ethanol, 30% chloroform and 10% glacial acetic acid. Okay. So we'll quickly revise the composition of Carnoy solution, and don't get confused if it is given either in terms of ml or percentage. Alright. The composition can be given either in terms of ml or percentage, so please don't get confused. In such questions, always take 2 minutes to recall what is the actual composition. Alright, so we'll quickly revise chemical cauterization, just the Carnoy solution part. So like I've told you, Carnoy's 1 is known as farmer's solution. It had absolute alcohol 3 ml and glacial acetic acid 1 ml, and it was not used clinically. Alright. So coming to Carnoy's 2, it was introduced by Zollinger and Cutler in clinics, and Stollinger recommended its use in OKC, that is your odontogenic keratocyst. It has absolute alcohol 6 ml, chloroform 3 ml, glacial acetic acid 1 ml and ferric chloride 0.1 gram per 10 ml. Alright, so this is the composition and this is important. Carnoy's 3 is modified Carnoy solution in which chloroform was omitted. Alright, because it was a carcinogen, so chloroform was omitted, and this Carnoy solution is used nowadays in clinics. Alright, so the recommended application time is 3 to 5 minutes, and penetration in various structures is, it penetrates 0.15 mm in nerve tissue, 0.5 mm in soft tissue and 1.5 mm in bony tissue or hard tissue. Okay. Coming to the next question, question 9. After closure of oroantral communication, when should suture be removed? Ideally, option A is 5 days, B is 7 days, C is 10 days, and D is removed only if infected. So what would be the answer over here? Answers, please. Any more answers do we have? Okay. So the answer here is option C, that is 10 days. Now quickly let's just revise the suture removal for as per various conditions. So facial skin and oral cavity, it is 5 to 7 days. Alright, eyelids 3 to 5 days, neck 7 days, scalp 7 to 10 days, trunks and limbs 10 to 14 days, oroantral fistula or communication 10 to 14 days, minimum is 10 days. Ideally for oroantral communication of fistula it is 14 days. Alright, ideally it is 14 days, but minimum of 10 days. You will never do suture removal for oroantral communication of fistula before 10 days. Alright, is it understood? Okay, I hope it is clear. Feel the dentistry. Shall we move ahead? So coming to question number 10, it says identify the instrument. Option A is jiggly saw, option B is bone gouge, C is bone file, and D is osteotome. No. 2 days, it cannot be 2 days, Komal. Wound will only not approximate in 2 days. It will lead to complete breakdown of wound. That's wrong. Okay, that is wrong. For a if for face on the face, if the suture is for the upper or lower eyelid, then minimum of 3 days maybe yes, but no. For facial sutures, 2 days is absolutely wrong. The wound will only not approximate. Okay. Because there would be no reference to a 2-day facial suture removal. That is why they have not given any reference. Okay. Please follow this table that I've given you. All right. Okay. Come to this question. Let's answer this question. More answers? Okay, so the answer here is option B, bone gouge. Now, so this bone gouge is similar to a spade or an excavator that you just insert it and you take off something. Alright, it is similar to that. So, what are the uses? It is used to remove dead or necrotic bone. Alright, it is used to harvest the cancellous portion during corticocancellous grafting. Okay. Okay, we'll update you regarding predictor series. Alright, Ria, we'll update you. Fine. It is used to harvest the cancellous portion during a corticocancellous grafting. These are the two main uses of a bone gouge. Alright, these are the two main uses of a bone gouge. I hope this is clear. Let's come on to our next question. Question 11. It says N-butyl cyanoacrylate is used for A. Hemostasis, B. Skin approximation, C. Disinfectant, and D. Impression making. So what would be the answer over here? Question number 11 answers. More answers. Yes, good. So N-butyl cyanoacrylate is for skin approximation. Alright, it is a tissue adhesive. Alright, it is a tissue adhesive. Now, very quickly, other wound closure methods, that means apart from sutures, we can use staples. So staples, I'm just zooming out, look like this. These are your skin staples. Alright, these are your skin staples. Okay. You can use tapes to approximate and you can use adhesives. So you should know the name of the adhesives. 2-octyl cyanoacrylate, N-butyl 2-cyanoacrylate, and isomyl 2-cyanoacrylate. Alright, these three are clinically in use. So you have to remember these three names. Okay. Coming to question number 12. After extraction of maxillary first molar, bubbling of blood is seen in socket on breathing. How will you manage such a situation? A. Pressure pack, B. Sinus lift and graft, C. Wound closure by primary suture, and D. Caldwell procedure. Okay, medical subjects will be taken by the medical faculty, but yes, all right, Seema, I will discuss this with the other others and with our coordinators. All right, and we will arrange a few sessions for medical subjects as well. All right, we will also try to arrange some revision session before your exam. Okay. Okay, more answers. Now, please understand, the question just says that their first molar extraction has taken place and there is some bubbling seen in the socket. Now, the question has not mentioned any dimension of the oroantral communication. All right, it has not mentioned anything else. No other information is given. All right, when no other information is given, you will simply do such a thing that will for sure short close the oroantral communication. All right, so that would be, you don't need to complicate such a situation, you just can suture. All right, so closure by primary suture would be the answer over here. All right, you will not give a pressure pack, or you will not give a pressure pack because here you do not know the dimension of the oroantral communication. So the best thing that you can do is, the management that you can do is, which will make sure that the communication collapses or closes, is by doing a suture, by doing suturing or giving a suture. All right, is it clear, Ashish and Feel the Dentistry? I hope it is clear to all of you. This how to approach such type of question where the dimension of the communication is not mentioned. Shall we move ahead? Coming to question number 13, which of the following is most well justified indication of open reduction and internal fixation in a subcondylar fracture? Okay, so option A is lateral extracapsular displacement, B is 20-degree displacement, C is condyle not in contact with the stump, and D is 2 mm shortening of ramus. Okay, so which of this would be the most well justified indication for ORIF in subcondylar fracture? More answers. Okay, so let's discuss this question. This is a little tricky question because of its options. Fine. Now this is your joint. All right. This is your glenoid fossa. Okay, this is the disc, and this is the condyle. So these all structures which are involved within the joint cavity, alright, these structures which are involved within the joint cavity, the glenoid fossa, the disc, and the condylar head, these are all your intracapsular. These are known as intracapsular, that is within the joint. They are present within the joint, or they are forming a part of the joint. They are intracapsular. Now the question says, option A says extracapsular displacement of condyle. Okay, that means the condyle has fractured and it is now lying over here, and the remaining portion of the mandible may be here. All right, extracapsular displacement, that means condylar head has displaced or is lying outside the confines of glenoid fossa. Okay, condylar head is lying outside the confines of glenoid fossa. That is what is meant by an extracapsular displacement. That means the condylar head is not now present within the capsule. It is not present within the capsule. Understood? So, whatever you may do, you will not be able to, especially by closed reduction. If you do a closed reduction, you will, that is IMF. If you do IMF, you will not be able to get this condylar head back into the confines of glenoid fossa. Okay, now there's option which says that the condyle, it is not in contact with the mandibular stump. Okay, okay, so maybe it is fractured like this. Okay, and maybe just now you have to imagine laterally, it is not possible for me to draw laterally. Maybe the condylar head is lying like this. Just imagine this to be lateral, and it is not in contact with the mandibular stump, but it is still present inside the glenoid fossa. The head is still present inside the glenoid fossa, but it is not in contact with the remaining mandibular stump. Alright, in this scenario, you can still do an IMF. Alright, you may still be able to achieve a reduction with IMF. Okay, so 20-degree displacement is not a contraindication. You can still, more than 30 is a more than 30 degrees of displacement is a indication for ORIF. Right, so this is also ruled out. Condyle not in contact with the stump. Which stump? Mandibular stump. Okay, so this also I just now explained that you can still use IMF to reduce. 2 mm shortening of ramus. So it is always more than 5 mm shortening of ramus where ORIF is indicated. So this is also ruled out. So the most strongest indication amongst the given option is ORIF. Yes, you can do ORIF for all the options, and you can manage all the other options with IMF except for this option, option A, lateral displacement or lateral extracapsular displacement. So this is a definitive indication for open reduction, internal fixation. Is it clear, everyone? I hope this question is now clear to everyone. We will move on to the last question now after this, and then quickly in 5 minutes I'll tell you about airways, and then when I'm taking the revision class, then I'll again also discuss your airways. Okay, Shall we move ahead? Is it clear, this question? Is it clear to all of you? Okay. Coming to the last discussion. Gina, I did not understand your doubt. We won't be able to join it with ORF? No, we will be able to join it. Are you asking me that extracapsular displacement we might not be able to fix with ORF? Is that your question? Okay. Let me know your doubt again. In the meanwhile, we'll discuss this last question. Question 14. A 32-year-old diabetic patient came for third molar extraction. After administration of LA, patient develops blurring of vision, dizziness, sweating. All of these symptoms are because of A. Hypoglycemia, B. Hyperglycemia, C. Anaphylaxis, and D. Inadvertent LA into infraorbital fissure. Yes. So the answer here is hypoglycemia. This is the correct answer. Okay. Fine. So just you have got this answer correct. Very good. Just for everyone to quickly understand again, there is a third molar extraction and patient develops blurring of vision, dizziness and sweating. Alright. Now, blurring of vision, don't mark this. This is wrong. You will never deposit in LA into the inferior orbital fissure. Even if you're doing a infraorbital foramen, infraorbital nerve block, then also you will not go into the inferior orbital fissure. No? So, alright, this is just to confuse you. So, yes, the correct answer is hypoglycemia. Okay, Gina, now coming to your doubt. The aim of ORF is always to anatomically reduce the fracture and then fix it. So even if the condyle is lying outside the confines of the glenoid fossa, the first maneuver is to get the condyle back, reduce it anatomically in the glenoid fossa. Second part is to reduce it with the remaining mandibular stump and then fix it. If we don't reduce it back into the glenoid fossa, we fix it without reducing it back into the glenoid fossa, we will never be able to achieve occlusion. Alright? So, with ORF, we can achieve that. Okay? Now, very briefly on airways. Okay? Now, I've told in my class also, 1 are airway maneuvers. Okay? 2 are mechanical airways. And 3 is your definitive airway. Okay? Now, head tilt, chin lift, jaw thrust. Okay? These are your airway maneuvers. Alright? Okay, I will come to the horizontal favorable, unfavorable also. Okay, these are your airway maneuvers. Jaw lift, head tilt, jaw thrust. These are your airway maneuvers. Okay. Now your mechanical airways. That is your oropharyngeal airway, also known as Gödel's airway, or your nasopharyngeal airway. Now in mechanical airways, we cannot ventilate the patient via mechanical airway for a long period of time. This is just to establish or maintain the patency of the airway till you get a definitive airway or till more help comes your way. Now, definitive airway is always your endotracheal intubation. Alright, endotracheal intubation. When we say endotracheal intubation, it can be orotracheal and nasotracheal. Alright, and again, both your endotracheal and nasotracheal can be non-cuffed and cuffed. Okay, so I have explained cuffed and non-cuffed in the last MCQ session, also last YouTube session, which I think we had on 12th. So you can go there and see. I've discussed one question also. Alright, apart from this, your different types of intubation like submental, RE, I will once again revise in our final revision class. Alright, this is just to give an overview. I will revise with visuals in our next class, which will be our revision class. Okay, now coming to horizontally favorable and unfavorable fractures. Okay, and here is favorable. Okay, now let's draw. So please remember horizontally. Why we are saying horizontally? Because we are viewing the mandible in a horizontal plane. Okay, we are viewing the mandible laterally in a horizontal plane. That's why we call it horizontally. Now, okay, just see this fracture line. From the superior border to the inferior border, the fracture line is running backwards. Alright, the fracture line is running backwards. So this segment will get displaced. Due to the action of masseter and medial pterygoid. Alright, due to the action of masseter and medial pterygoid. Okay, so this becomes your horizontally unfavorable fracture. Now let us see what is happening in favorable fracture. So basically your favorability and unfavorability entirely depends on the direction of your fracture line. Okay, Now, if you see the fracture line in a favorable fracture, from the superior border to inferior border, the line is running forwards. Alright, the line is running forwards. So what will happen in such a scenario? This ledge of bone will prevent the displacement of the posterior segment. Alright, it will not get displaced because this ledge of bone here, this prevents displacement. Okay, is it clear? Is it clear, Nikesh? Favorable and unfavorable? And airway, who had asked me regarding airway, is it clear to all of you? Shall we wind up the session? Okay, great. I think Akansha had asked me for airway. Is it clear, Akansha, if you're there? Okay. Any other doubts or anything you want to convey to me? Or shall we wind up the session? Okay, so we'll wind up this session. Thank you, students. Keep studying. All the very best for your exam. And you can always ask your doubts on the WhatsApp group. Thank you so much.